Hey guys, Miss Hill here, and I am recording a lecture for Individual Module 5.2. This is PowerPoint 2, Lecture 1, and I'm recording this for the fall class of 2019. So here are your learning outcomes, and today we are going to be talking about intrapartum care and specifically maternal and fetal assessments and some alterations. So we're going to start out talking about the maternal and fetal assessments during intrapartum care. For the maternal assessment, sorry y'all, somebody's pulling in my driveway. Let me pause. Okay guys, it was just my husband. All right, so when we do a maternal assessment, we start out initially by screening the mom for any type of risk factors. Obviously, whenever we do an assessment on anybody, we would introduce ourselves first. And with maternal assessments in the intrapartum period, we want to have a good idea of what her history is and if she is at risk for anything that could put her or the fetus at danger during the labor and delivery process. We always get an immediate assessment of maternal vital signs, and not just maternal vital signs, but also hook her up to the electronic fetal monitor and get an interpretation of the fetal heart rate as well. Typically, most places have prenatal records available whenever a mom comes in for delivery. So a review of her prenatal records and her prenatal care throughout pregnancy is also very important. And that can also tell you if she has any type of risk factors. It can also, you can look at ultrasound reports to see where the placenta is located. All very important pieces of information to know how the baby is positioned on the last ultrasound, lab work from her first prenatal visit and throughout her care. So an admissions interview for these people, which is what we initially do, includes things such as the woman's name and her age. We talk about religious preferences and spiritual practices because all of those things factor into the intrapartum nursing care that you're going to provide for somebody. We always want to know when her last menstrual period was. So the first day of her last menstrual period, we can figure out NAGEL's rule by that and get us an estimated date of birth so we know whether or not this mom is preterm, is she term, what's her gestation. We talk about personal history, medical problems that she might have, past surgeries that she might have had. All that's very important whenever somebody is going through the labor process. If she has had some type of uterine surgery in the past unrelated to pregnancy, we would want to know that because it could put her at risk for things like uterine rupture or dystocia, which means just a sort of a dysfunctional labor pattern. We also want to know what her preferences are for labor and birth. In the last PowerPoint, we talked about how empowerment during the labor and delivery period is key for the mom to look back and emotionally and psychologically look back on her experience as a positive one. So if we can know what those preferences are ahead of time, we can better help her feel empowered through the process, and we can also sort of work around some things that she may not particularly want to do, but we might be able to sort of guide her to make decisions in that manner if it's what is best for her and the baby. We also want to ask about the onset of labor. So when did her contractions begin, or when did her water break, if it has? That's a super important question, because you want to know when all this started. How far along are we? Intrapartum high-risk screening is also an integral part of assessing the woman who is in labor. We need to know if she's had periods of bleeding, what position is the baby in. So again, that information you can get from ultrasound reports, from prenatal records. You can also do Leopold's maneuvers to try to determine what the position the baby's in, and a lot of the times the mom can tell you. Is she a poverty-stricken mother? That will affect the type of care she's received. That might affect her true nutritional status. It might affect her support system. It might have affected her ability to get prenatal care. It's very easy in nursing, and not just labor and delivery, but it is very easy in all areas of nursing to become a little judgy of people because they aren't taking care of themselves. But it is always so important to take a step back and try to figure out where your patient is coming from, because it may not be that your mom didn't get prenatal care because she didn't want to or she didn't care. It may be because literally she had no ride to get her to the doctor's office. She truly could not get there. So try not to be judgmental of people whenever you're asking questions and you're getting answers. We want to know if she has any history of mental illness, and the way to find that out is to either look in the prenatal records, but if she's had no prenatal care, you just ask. You just flat out ask them. Does she have any type of post-traumatic stress disorder? Because that can also affect how she responds to the pain of labor. It can also have a bearing on how she would respond to an emergency situation if there had to be a stat C-section, that was called, during the process, because those things they happen very quickly, and there's a lot of noise and people coming in and out of the room. So somebody with mental illness or post-traumatic stress disorder will respond very differently than somebody who has some healthy mental health. Is she a smoker? Did she use drugs, or did she drink during pregnancy? All extremely important to know from a fetal perspective, really, because she would be at risk for abruption. The baby might have some intrauterine growth restriction because of some of those uses of drugs or cigarettes. And those would be all important things you want to be prepared for when the baby is born. And then from a physical and a psychosociocultural standpoint, we would proceed with a physical exam. So you can see how this started off with a couple of questions for the mom, a little interview, we're reviewing prenatal records, and now we're moving on to the physical exam. We perform those assessments immediately upon admission, and a lot of the times these things are done at the same time. We're asking questions and doing the physical exam at the same time, but we always want to establish a rapport with our patients to begin with, because this is a very personal experience for them, and we're doing some pretty invasive exams on these people. We continue our assessments throughout this process. This is not just a physical exam upon admission and for the shift, and we document that and we go on with our day. We are constantly doing a physical exam and an ongoing assessment on the mom and the baby when they are admitted for labor. What's her psychosocial history? Does she take any type of psychotropic medications that can affect the fetus, and can also affect how she responds to the labor process? If she's on those medications, has she been taking them like she's supposed to? The communication pattern between you and the patient, and between the patient and the support person, is something that is very key. She has to be able to feel like she can communicate with you as the nurse for her labor and delivery to progress in a manner that's acceptable for her and that she'd have a good outlook on. And then as the nurse, you should be assessing the communication pattern between her and her support person. That will give you some really specific cues about how supportive that support person is. Is it a healthy relationship? And is it going to benefit her throughout the labor and delivery process? And make sure that we're providing information in her primary language. So if you're giving her things to read, you're giving her information about how the process is going to go. Communicate through a language line if she doesn't speak English. Make sure you provide handouts in whatever language it is that she speaks. So around here, it's typically Spanish. And if you don't have the ability to provide those handouts in Spanish, then call the language line and have the language line read the document to her in Spanish. Women from some cultures might decline pain medication, and it's important for you to know that up front, which is why we ask them about how they anticipate the process to go. We want to know what they want to happen. If they don't want an epidural, then we need to be able to give them information on other types of pain medications. And if they don't want any pain medications at all, we want to talk to them about the implications of those decisions, which is fine, but we want to have those conversations with them up front and let them know, hey, when you get to the transition stage of labor, things are going to be super tough, and I will help you get through it without any pain medication. I will help you with breathing exercises. I will help you focus, but just know that when you get to that point, we can't change our mind at that point and give you anything, because typically at that point it's too late. So she needs to know those things up front, because if we don't explain things at a point in labor where she is acceptable to teaching and can actually has the focus to be able to hear you, then sometimes our education doesn't get across quite as well, especially if they're having a lot of pain. In some cultures, the partner is not expected to be present in the birthing area. For a typical kind of Anglo family, that is what is expected. So try to remember to not be judgy and not be pushy about the support person being, or the partner being, in the room, because we see that as something that's a very normal, but some cultures do not. So always know who you're dealing with. And what are her values and her beliefs? Those are very important when it comes to labor and delivery as well. Is she okay with people, certain people being in the room with her when she delivers? Is she an Orthodox Jew, and is she delivering on the Sabbath? There are so many different things, and if you don't know what they are, then you can just ask. It's okay. ideas, knowledge, fantasies, and fears about childbearing, all of those are important for you to know as the labor nurse. And as you stay with your patient and you get your assessment done and you're talking to them throughout their stay, you'll find out these things. But it's also important to be pointed about your questions and ask them, hey, what do you know about this process? Have you done it before? Tell me what you expect. How would you like this to go? What are you most afraid about? And you can help navigate her through this whole process, and she can have a wonderful outcome. And the cool thing is that you as the nurse actually can help that happen. You're like the Uber driver for her labor and delivery experience. It's kind of cool. Pay a special attention to her body language. So especially for people from cultures that, and not even just cultures, but in general, some people can be very stoic about how they approach pain. And so pay attention to their body language. They may not tell you that they are in pain, and they may be very stoic about it, but pay a close attention to changes in their nonverbal behaviors, in their positioning, so that you can specifically target your questions to find out information and to help them. Moving deeper into the maternal assessment, contractions are obviously a huge part of the maternal assessment during labor and delivery. We have to assess the nature of the contractions and if they're painful to the patient. Remembering that the patient's perception of pain is key. If this is an adolescent mom who has never had a contraction or experienced any real pain in her life, she is going to have a different perception of the early stage of labor than a person who has had 4 children. And she's going to think it's the worst thing she's ever felt, and it very well may be, but she also needs to be prepared for the fact that it is going to get worse. We typically assess contractions with an external monitor, and it's called a tocodiameter. A lot of the times we just call it a toco, and it's positioned right on top of the fundus of the uterus. So again, you got to do a little abdominal assessment, be able to feel where the fundus is at, so you can place the toco in the correct position. And the toco just measures pressure from an external perspective. So it's an estimate of what contractions are, which is why when you're doing an assessment of contractions, you have to always lay your hand on the mom's belly so that you can feel what is going on at the peak of a contraction, and you can feel what her belly feels like at resting tone. The toco will provide you with a continuous recording of those contractions as long as it's placed appropriately. And we can also assess contractions through an internal electronic monitor, and that type of monitor is called an intrauterine pressure catheter, or an IUPC. It gives you the same data as the external monitor, but it gives you an accurate measurement down to millimeters of mercury in terms of intensity of every single contraction. So we get a very specific reading that is accurate. The external monitor gives us a specific reading, but it is only an estimate. An intrauterine pressure catheter can be placed by a nurse, not in North Carolina. In North Carolina, you are required to have an advanced care provider place those. The bag of waters has to be ruptured for you to get one of these in, and it's just a little, it's like a huge IV catheter sort of, and it is placed inside of the mom's uterus, and there's a little pressure sensor on the end of that, so that whenever a contraction happens, that's how it gives us that pressure reading. But it's just slipped in sort of right by the baby's head up into the uterus. Cervical assessment is also very important during the labor and delivery period, and we do that by a direct sterile vaginal exam. You have to put on a sterile glove to do a cervical assessment. We do use lubrication to do that, and we're feeling for how much the cervix is opened up. So dilation, we measure that in centimeters, and then effacement, how much is the cervix thinned out, and we measure that in percent from 0 to 100%, and then dilation is 0 to 10 centimeters. We can also get information about the adequacy of the mom's pelvis. We can tell if her membranes are ruptured or not. Do we see amniotic fluid? And we can determine fetal position and station whenever we do a cervical assessment. So it can give us a lot of information. We don't typically do the cervical assessment a lot during the first stages of labor. We might do a cervical exam on admission, and then we allow the mom to labor. If we start seeing signs in the fetal heart rate that tells us the baby may have descended some or changed positions a little, then we might want to do another cervical exam. If our mom starts to complain of pressure or feeling like she has to go to the bathroom, then we might want to do a cervical exam. So a bunch of different reasons as to why we time them the way we do, but there's no specific time pattern for doing a sterile vaginal exam. It's a nursing measure that we use as an assessment tool, and if we notice that we need to up the game and do those assessments a little more frequently, then we do. Okay, so from a fetal standpoint, what types of things do we look for in the baby? Well, we can assess fetal position in several different ways. We can inspect the abdomen. We can palpate the abdomen using Leopold's maneuvers. We can do a vaginal exam and determine what our presenting part is. There is also ultrasound, so we can look back at prenatal records for ultrasound information. And we can auscultate the fetal heart rate. So depending where you have to put the ultrasound monitor on mom's belly can give you a clue as to how the baby is positioned in utero, anterior or posterior, or head down or breech. So here's another photograph of Leopold's maneuver. It should look familiar because you saw it in IM 5.2. And what's the significance of this assessment? The significance is that it can help you determine if the baby is vertex or not. It can help you determine if the baby is engaged into the pelvis or not. And it can help you determine attitude. Is the baby anterior or posterior? If you can do Leopold's maneuvers and get it and be accurate about it, you can also determine the best place to put the ultrasound monitor on mom for fetal heart rate tracing. Okay, so there are a bunch of different ways that we can do the fetal heart rate assessment, and we can auscultate the fetal heart rate with a few different types of devices. We can use a fetoscope or a Doppler, and this one that looks like the stethoscope with the weird looking bell, that's a fetoscope. And we can also use a Doppler, which you should be familiar with, to measure fetal heart rate. Typically these two types of devices are used in places that are not acute care facilities. So your alternative birthing centers. Now, in an acute care facility, we do use the Doppler, but mostly in the acute care setting, you're going to see fetal heart rate assessment being done via an electronic fetal monitor. And typically, it's going to be a continuous monitoring. We want to assess fetal heart rate every 30 minutes in a normal patient that's having normal labor, and every 15 minutes in a high-risk person that's having that has some high-risk factors. So there again, the individuals in an acute care setting are typically going to be on a continuous monitor, so that every 30 minutes and that every 15 minutes may end up being what you're where you're charting, where you're documenting the fetal heart rate every 30 minutes or documenting the fetal heart rate every 15 minutes if they're on a continuous monitor. Or it could be your patient who has orders that they can get up and ambulate. And if they can ambulate around the labor unit, then for that normal mom, we would just put her back in bed and get a good fetal heart rate tracing every 30 minutes. These time frames vary from facility to facility and from labor unit to labor unit. So don't get so caught up in the numbers, but just know that they're guided by policy and they do change from place to place. Again, fetal monitoring can be continuous or intermittent. We can do it from an external standpoint with that TOCO to measure contractions and the ultrasound Doppler to measure the fetal heart rate, all externally on the mom's belly. We can do it from an internal standpoint where we have an intrauterine pressure catheter that is placed inside mom's uterus to give us an exact measurement of contraction pressure. And we can also use an internal monitor for the baby's heart rate, and that's called a fetal scalp electrode. It's placed directly into the baby's scalp and allows us to measure heart rate that way. So we can do it externally or internally, or we can combine the two types of assessment the assessment devices, and we might be able to monitor contractions internally and monitor the fetal heart rate externally, or vice versa. When we are monitoring the fetal heart rate, we are trying to interpret a couple of different things. We want to know what the baseline is, and then we're also looking for any type of periodic changes in that fetal heart rate. And those periodic changes become very specific, meaning are there accelerations, are there decelerations, what type of decelerations are there? Are they lates? Are they earlies? Are they variables? What is the variability? If they're accelerations, are they 15 by 15s or are they 10 by 10s? And how do all of those things relate to the contractions that you are monitoring? This item over here in the bottom left-hand or the bottom right-hand corner of the screen, that's an intrauterine pressure catheter. The end of it here where there's a yellow cap is what plugs into the cord that runs to the electronic fetal monitor. This little blue cap is actually a port, a Lure lock port. So you can run IV fluids through this catheter up into the uterus if we need to do an amnio infusion. And right at the end here, there's a little pressure sensor, and that's what measures your contractions. This white part here, sort of in the middle, is just a guide to keep this catheter straight as it's inserted. So that actually comes off once it's inserted into mom. So electronic fetal monitoring produces a continuous tracing of the fetal heart rate. And in this photograph, you see the mom who's hooked up to the fetal monitor. She has got those straps around her belly, and she has external monitoring. She has a TOCO and a Doppler ultrasound on her belly. Indications for this type of monitoring would be patients who've had a history of stillbirth greater than 38 weeks. They've got some type of complications going on for their during their pregnancy, so they're high risk for some reason. Moms who are having labor induced, those individuals have to have continuous fetal heart rate monitoring. Moms who've had decreased fetal movement or reports that to you. Moms who have meconium stained amniotic fluid. What we know about meconium is that if the baby releases meconium in utero, there has been some type of hypoxic event at some point to occur, for that to occur. So those individuals would be on continuous tracings. And then maternal fever is the mom running a fever. That's a sign for infection, and we would definitely want to continuously monitor her, because an infection in mom can actually cause the fetal heart rate to increase and become tachycardic. And then another population would be those individuals who've had a C-section and now they are going to try to VBAC or have a vaginal birth after cesarean. And what we do with those individuals is if it's their second time around, they had a C-section the first time and now they want to try to deliver vaginally, we will do a trial of labor with them initially, and they have to be on continuous monitoring for that. Again, there are different methods of electronic monitoring. Ultrasound, we have to be careful to make sure that we're tracking the fetal heart rate and not the mother's whenever we're using this external method. There are also new ambient, so the ultrasound, that would be the Doppler. There are also new telemetry systems, fairly new. They're not really all that new. But there are telemetry systems now that allow the mom to get up and walk around the labor unit and ambulate, that allows her to continue to be on continuous monitoring even when she's walking around. Some of them can even be worn during water births or when they're submerged in a tub. So it's just like a telemetry cardiac monitor, except for it measures the baby's heart rate. And then internal monitoring with a spiral electrode, or a fetal scalp electrode is what we call that. That would be the internal type of electronic fetal heart rate monitoring that we would use if the ultrasound Doppler is not working well for us. To be able to place one of those, the membranes have to be ruptured. The cervix has to be at least 2 centimeters dilated, and you have to be able to place it on a bony part of the fetal skull. It doesn't, we don't place it on the sacrum. It has to be, so not on a breech baby. Baby has to be head down. And we place it on a bony prominence. The key things are to make sure that it's not screwed into a fontanelle. So you have to make sure you're on a bony prominence. And it provides you with a very accurate fetal tracing of that heart rate that is not interrupted when the mom moves or is bearing down to push. It gives us just a really good electronic heart rate tracing. But it can injure the fetus because it is a tiny little wire. Well, it's a little spiral wire, and it's actually just twisted into the scalp, so it can potentially cause infection in the baby. And if you place it into a fontanelle or an eye, that's obviously not good. So you got to be sure you know where we're putting it on. Nurses are able to do this with training. But we would never do this for somebody who had like GBS, a mom who had a GBS positive status, who was HIV positive, any type of infection like that, we would not want to put a fetal scalp electrode on this baby for a mom of that type status. So what are the maternal responses to electronic monitoring? Well, some people don't mind it because they know that it is what the nurses are doing to try to keep track of the baby and make sure that the baby is doing okay during labor. And they know that it will help us identify problems that occur throughout labor and that we can react to change them. However, sorry, y'all, the clock is going off. Some women may be very ambivalent or negative about it. They might believe, especially your natural birthing moms, they don't want any type of intervention. They want to do it all natural. So they may not want to do this. They might resent that you're spending your time focusing on the fetal heart rate monitor instead of providing them with support or care, or what they feel like you might not be providing them with nursing care. They might be a little more anxious because of the equipment. They might feel tied down or claustrophobic. The sounds that come from the fetal heart rate might bother them. And they might be uncomfortable just lying in that one position so that you can trace that fetal heart rate for long periods of time. And some of them might be fearful of injury to the baby, specifically when we're talking about internal monitors like the IUPC or the fetal scalp electrode. We can also monitor fetal oxygen saturation, and that can be done by using a type of intra-monitoring tool that gives us a pulse oximetry for the baby, and it just plugs into the fetal heart rate monitor and it gives you real-time oxygen saturation values for the baby. It rests right against the baby's cheek. Again, to place one of these, you would have to have ruptured membranes. You would have to be very aware of infection status from the mom. And what's normal for a fetus are oxygen saturation somewhere between 40 and 70%. So that seems really low because what we want grown-ups to be at, or, well, anybody who's breathing air, what we want them to be at is, you know, at least 95 or above, right? But you have to remember that the fetal system works completely differently than somebody who is outside of the womb. So normal oxygen saturation for a fetus being 40 to 70 is not bad from an oxygenation standpoint because their heart works differently. And they're getting their oxygenation through the placenta and not by actual breathing mechanisms. Cord blood pH sampling is also something that we can do after delivery. The physician can hand you a section of the cord, and if he asks for a cord blood pH, then you would draw that from the umbilical artery, one of the two, and you do it immediately following delivery, and we put it on ice until respiratory therapy can run it on their machine or the lab. And a normal pH is 7.25 or greater. That's what we want to see. Anything that's less than 7.2 will indicate some type of fetal acidosis, which means there's been some kind of hypoxia. It's also possible to do fetal scalp blood sampling to determine oxygenation as well, and same rules apply. 7.25 is normal, and anything less than 7.2 means that there is some type of fetal hypoxia. The thing with fetal scalp blood sampling is that you can actually do it while the baby is still in utero, so during labor and delivery. And if we get a result of less than 7.2, that indicates there's some hypoxia going on, and we can actually immediately intervene to help turn that around. For cord blood sampling, it is really more of a protective measure for an assessment technique for the physician after the fact. A lot of the times, cord blood pH sampling are drawn and used for litigation purposes if there ever were to be some type of lawsuit, or they're used for mitigation purposes regarding legal matters. So if you've had a patient during labor and delivery who you've had some late decelerations, or they've had a lot of variables on the fetal heart rate tracing throughout labor, the physician might want a cord blood sample, and if it's 7.25 or greater, then that's a good sign, because it means that even though despite that fetal heart rate tracing that wasn't great, there weren't any true hypoxic events that caused the pH to decrease or the baby to become acidotic. So it can be a good bit of legal information to have if the physician were to ever get sued. So that's sometimes why they do the cord pH. So what are our intrauterine resuscitation measures? What do we do for these people if we determine that the fetal heart rate is not looking like we want it to? One of the first things that we do, again, all of these things are so individualized based upon the patient and what is going on. So these are all things that we do, but which one would we do first? So what's our priority really depends on the scenario of the patient and what is going on. So repositioning is a big one, big intrauterine resuscitation measure. We can put these patients side lying, preferably on the left. We can put them in knee chest position if things are severe. Administering oxygen at 10 liters by mask is important to get that oxygenation to the fetus, not necessarily for mom all the time. An IV bolus, discontinuing any drips that you have going or meds that you are continuously giving. Maybe putting on a fetal scalp electrode to help you better assess the fetal heart rate if we're using an external monitor. We might want to do some fetal scalp stimulation, possible amnio infusion, but you would have to have an order for those things. Preparing the patient for a C-section, administering any type of ordered medications. If there are too many contractions, giving some terbutaline. If blood pressure is too high, maybe some magnesium. If blood pressure is too low, maybe some ephedrine. Again, all things that you have to have orders for and very individualized per patient and what's going on. We might have to call the healthcare provider, communicating with your nursery staff so they know what's going on, putting the patient on a continuous monitor instead of an intermittent monitoring of the fetal heart rate. Making sure you know what the mom's vital signs are, keeping up with those very frequently, assessing her labor progress. You might have to do a sterile vaginal exam, and then always keeping the patient and the family informed as much as possible. It's very important, again, for those individuals to feel empowered. And if you're having to use intrauterine resuscitation measures for the fetus, then there is some type, they can sense some type of turmoil. They know something is not quite right if you're asking them to do these things, or you're starting to give them meds that aren't ones that you've talked about initially. So important to keep them informed of what is going on so they have some feeling of empowerment still through the process. Okay, so moving on to the care of the patient with vaginal delivery. For the labor assessment of the patient who is going to have a vaginal delivery, it's important to know how quickly is that going to happen, so the imminency of delivery. You determine that by sterile vaginal exam. Getting that good prenatal history and making sure you're aware of any high-risk screenings, doing your physical exam to include vital signs, knowing what the contraction pattern and the fetal heart rate pattern is, knowing whether or not her membranes are ruptured. If they did rupture, what time did it happen? How much fluid was it? What did it look like? Those are all important questions to ask your patient if it didn't happen in the hospital. If it did happen in the hospital and you witnessed it, then what time did it happen? What does the fetal heart rate look like now that the membranes have ruptured? How much fluid was there? What does it look like? All of those are important things to document. Are you seeing any bleeding? Are there signs of bloody show? Is it more than it was? And then Leopold's maneuver, so you can determine if the baby is engaged, what position the baby is turned in, and then of course your laboratory diagnostic tools, so your urine test, urine analysis, and any type of blood sampling that we have to do, so all those tests. Again, from a fetal standpoint, for a vaginal delivery, we want to know what the fetal heart rate pattern looks like. What's the baseline? What type of periodic changes are we seeing? It is most important to evaluate the fetal status. So that's why we have to know those things. What position's the baby in? Is the baby in an OA position, so occiput anterior, or in an OP position, occiput posterior? And remember, we want those babies to be in an anterior position. Labor will progress the best if the fetus is in an anterior position. And then what's the presentation of that baby? Hopefully it's cephalic, and hopefully that baby is vertex presenting. Or do we have a malpresentation when you do your sterile vaginal exam? Are you feeling an acromion? Are you feeling the sacrum? This top photograph is a picture of the fetal scalp electrode. It's a little difficult to see, kind of blurry, but at the very end of that, you can see a little spiral, a little silver looking thing. It's a little teeny tiny wire, and that's what screws into the baby's head. So here's a picture of what that would look like on the bottom. All right, so let's talk about what we would do during every stage of labor. So during the first stage of the latent phase of labor, we're going to do some different types of assessments and interventions for these women. We are going to provide nursing care for them in the first stage, and mainly we're going to be focused on comfort. We can encourage ambulation if there are no contraindications, so meaning we would never encourage someone to ambulate if their membranes were ruptured but the presenting part was not engaged. So if again, we would never encourage ambulation for someone who had rupture of membranes, but the presenting part was not engaged into the pelvis. And the reason for that is because the cord could slip through and past that presenting part into the pelvis, and cut off oxygenation supply to the fetus. That's very important. But positioning these people for comfort, helping her onto her back or elevating the head of the bed, getting her socks or slippers if her feet are cold, making sure the temperature in the room is nice, fresh bed linens, and if her membranes are ruptured, or even if not, she's having lots of bloody show, making sure you're changing the pads out on her bed. Helping her to empty her bladder regularly will help labor and delivery go much quicker, help this latent phase progress. Always keeping the support people and the family members comfortable as well, because they can also be anxious just like the patient. And from an anxiety standpoint, as the nurse, making sure that you're handling that, give them information, establish a good rapport, stay with the patient at her bedside if she's feeling anxious, help her with breathing techniques, and encourage her, tell her she's doing a good job when she is. And then, this is the phase where you can teach the most, in the latent phase, because they're not too far gone down the pain path to hear what you're saying. So do your teaching, be truthful about what's going to happen in the next several hours. Make sure that that you're aware of her stress level. Talk to her about contractions and how they will continue to get worse. Talk to her about pain medications, and teach her about the different types available where you are. And then also making sure that you're aware of those nonverbal cues. So from an assessment standpoint, again, many of the things are very similar to what we've talked about already. So Leopold's maneuvers, sterile vaginal exam, rupture of membranes, palpating the bladder. We're going to be doing maternal vital signs every 30 to 60 minutes during the latent phase of the first stage. And again, all of this is guided by the policy of the place you're at. So these are general, sort of general rules of thumb. We do a temperature every 4 hours if the bag of waters are intact, and usually every 1 to 2 hours if the membranes are ruptured, and that all has to do with risk for infection. We're going to palpate the uterus during a contraction every 30 minutes, and probably even more frequently than that. We want to auscultate the fetal heart rate every 30 minutes for a low-risk person, and every 15 minutes for a high-risk one. And then we'll intervene by providing them education, giving them coaching and relaxation techniques, promoting their comfort, positioning, and pretty much I've talked about all of these. Offering food and fluids as desired unless complications exist that may necessitate general anesthesia. For your people in the acute care facility, that's going to be just about everybody. I don't know any acute care facility where they will allow a mom in labor to actually eat. She can have ice chips and popsicles and like suckers or clear candy, but like a Jolly Rancher or something like that. But we don't feed these people in an acute care facility typically. And in low risk settings, so your low risk patients who are in like a birthing center or an alternative birthing center, those individuals do get to eat. But this last bullet here that says it's not necessary to restrict intake in a low risk setting. So for low risk patients in the hospital, it really is not necessary to restrict their intake. The research shows. It shows that really they're able to eat during this phase of labor, and it's okay that the outcomes haven't shown it to be harmful from a maternal standpoint. However, acute care facilities and labor and delivery units really haven't caught up with this research yet, and it's really a struggle between the OB and the anesthesiologist. So if this mom's getting an epidural or anesthesia has the potential to be involved at any point, and the argument can be made that if you're having a baby, anesthesia has the potential to be involved at some point for everybody, 100% of patients, because you never know what the fetal heart rate's going to do. So that's why we don't tend to feed people. But the research shows us a little different, so there's your little evidence-based practice knowledge. For the active phase of the first stage, okay, so this is where the mom is dilated somewhere between 4 and 7-ish centimeters, right? Things are starting to get real. We're going to do sterile vaginal exams, still looking for rupture of membranes, palpating the bladder. All of these assessment techniques are the same, and even the time frame, palpating contractions every 30 minutes and auscultating fetal heart rate every 15 to 30, depending on whether you have a low or a high risk patient. So for the high risk patient, every 15 minutes, for the low risk patient, every 30 minutes. We're still going to continue to provide monitoring, educate them on the labor process as much as possible, because during this phase, they're starting to become inward focused. They're starting to hurt a little more. They're having to regroup themselves. Coaching them on relaxation techniques, helping promote comfort. So we might have to start getting epidurals at this point. Coaching them with breathing techniques, helping them with position changes because they're going to feel like moving around. They're going to be uncomfortable. And if it's not contraindicated, so the mom has a baby who's engaged and she's not high risk for anything else, encouraging her to ambulate if you have an order for that. That can help. Can help take her mind off of just lying in bed and hurting. Encouraging her to void every couple of hours. During the active phase, we're going to try to limit sterile vaginal exams as much as we can throughout the labor process so that we can avoid infection risk. Keeping an eye on that bladder is really important during the active phase too, because if the bladder gets full with urine, it can interfere with fetal descent into the pelvis and cause labor to be longer than necessary. If the patient cannot void for you, doing an in and out cath might be necessary. If the mom's membranes have ruptured, it really varies based on the patient, but if membranes ruptured at home and it's been 24 hours of labor, the physician may go ahead and decide he's going to deliver the baby, whether or not labor has progressed. So they won't usually go longer than 48 hours with membranes ruptured for a normal labor and delivery. The provider may allow the pregnancy to continue with monitoring at that point, unless the mother starts to develop signs of infection. And if that's the case, we can administer some antibiotics and maybe start using some induction methods on a case-by-case basis. For that prolapsed cord, so we were talking about ambulation if it's not contraindicated. If a cord becomes prolapsed when membranes rupture, so we have a patient who has a really strong contraction and we have a spontaneous rupture of membranes, and then all of a sudden we do our sterile vaginal exam because that would be an indication that we would want to do one of those. We've had a change in condition. And the labor nurse would want to do a vaginal exam at that point to see what things were like. But she's also going to be looking for cord prolapse, because as all that fluid gushes out, if the baby is not engaged, there is a potential for the cord to sort of rush out with that fluid. And if that happens, on a sterile vaginal exam, you'll be able to feel that. You'll be able to feel a pulsating structure. And if the labor nurse feels that, the immediate intervention is to remove pressure on that cord. And so you do that by leaving your hand in and pushing the presenting part up and off of the cord as much as possible. This is an emergency situation. That patient will have a C-section. The other things that you might do is flip your mom onto knee chest position. So butt way up in the air, chest on the bed, and she would be flipped over and with, sort of face to the bed. But the labor nurse would never remove her hand from that sterile vaginal exam. You would continue to keep pressure off of the presenting part if if the cord prolapsed. From a comfort standpoint during the active phase, it is important for the labor nurse to help be supportive of relaxation techniques. Moms who have tense muscles, that increases the resistance to the natural process of labor. It will cause her to become fatigued much more quickly, and it will also increase her perception of the pain that she is having. So keeping moms relaxed from a muscular standpoint is really important, having them to try to relax and not tense up. And a lot of that can be done through just breathing techniques, encouraging her to rest and relax between contractions, because contractions are stressful and they are very tiresome. Limiting the number of visitors and interruptions during the active phase can also be helpful for the mom, because sometimes they don't want to hurt anybody's feelings, and they really don't want anybody around but their support person and their nurse. But you've got grandparents who are excited and they want to be coming to visit, friends that want to be showing up, because remember, she's just gone through the Facebook stage of the latent phase. She's let everybody know she's there, and now they're showing up and she's in the active phase. But now she's regretful because she doesn't want them to come in. She's hurting too bad. She's more focused on herself. She doesn't feel like she can give them, she doesn't want people all around her bedside gawking at her, but she doesn't want to hurt anybody's feelings. So sometimes the labor nurse comes in handy at that point by helping her to limit that number of visitors or interruptions. Distractions from a comfort standpoint can be helpful. So a nice TV show, possibly helping, maybe playing cards with her in between contractions, or helping her visualize pleasant places to be or experiences. Really truthfully in the real world, not how sure those things work, but and then some women like to be touched. Some women want you to give them a little massage, especially if they're having some back labor, some providing counter pressure on their sacral area might be helpful. It might relieve some of the pain, but some women also don't want to be touched during this point. They don't want you putting your hands on them, even to palpate for contractions. So you have to know your patient. And during the active phase is where we're going to start giving some type of pain meds if that's what she wants. So we're going to start getting that epidural the anesthesiologist to come up and do the epidural, or we may be giving some other types of medications, some narcotics, and some adjunct meds to go along with that, like Phenergan, Vistaril. During the transition phase, this is the get it out phase. You're going to be doing your sterile vaginal exams much more frequently because things are changing quickly during this phase. Again, assessing rupture of membranes and bladder palpation, You're going to be recording fetal heart rate, maternal vital signs around the same time frames as we've talked about previously. But the difference here is we're going to be monitoring pain continuously. You're going to be at the bedside with mom. You're going to continue to provide monitoring. You're going to still continue to encourage voiding as well. Continue educating her on the labor process as much as possible. So if there are things that you need to teach her about, you're going to teach her those things during rest periods between contractions. And likely she may or may not be receptive depending on what kind of pain control she's using. You're going to implement comfort measures. That is super important during this phase. Encourage pant, blow breathing. And they're going to start feeling an enormous amount of pressure during the transition phase. So helping them to implement that breathing and helping them focus on something else other than the pressure is very important, because we don't want them to start pushing until they're fully dilated, so that we can avoid cervical tears and cervical edema that will stop the labor process. And listen to them whenever they say they have complaints of pressure. If they tell you that they have got to push, or that they have pressure that is unbearable, or that they're going to have to go to the bathroom, if they say those things to you, you better listen and do a sterile vaginal exam to determine if they're dilated or not. Prepare for the birth. Make sure your table and your instruments are ready and that your doctor is aware that things are close. Observe for any of the signs of delivery, such as perineal bulging, crowning of the baby, and encourage her to start bearing down when she's fully dilated. So help her push a few times to see how well she does that. At the end of the transition phase and the beginning of the second stage of labor, or the pushing stage, you might be able to kind of tell just because of changes in her voice or sounds that she starts to make. Their voices tend to kind of deepen at this point. It becomes more guttural of a sound. From a breathing technique standpoint, during this phase of labor, there are really kind of 3 levels of patterned and paced breathing that you can help the woman do. We can do slow, deep breathing, where we take a breathe in through the nose and blow out through the mouth very slowly. We can do shallow or modified paced breathing, and then there's the pant blow. And all of these things help to keep her from hyperventilating as well. Abdominal breathing is what you're going to hopefully be able to see. If hyperventilation does happen, then encouraging her to slow things down and take shallow breaths, or giving the typical paper bag also can be helpful. Some women bring what we call a doula with them. They'll hire somebody whose specifically sole purpose is to be there and encourage them through labor and coach them through the breathing process and coach them through the pain. And if the doula is there, she is somebody they're paying to be there with her, and she has special training, or she or he has special training to help get mom through this labor and delivery process, and she'll provide continued encouragement and support with each contraction. So just be aware if mom has someone like that, and be respectful of them at the bedside, because they are serving a support role for that mom. And I always like to mention pain medications during the transition phase because this is probably the worst part of the first stage of labor. Yet it is the phase of labor where we cannot give any pain medications in regards to like narcotics because this phase happens pretty quickly and there's not time for the baby to get over the effects of those narcotics before being born usually. So if you've had a mom who has gotten some pain medication during the active phase, but then things progressed super quickly and she is delivering within just a few minutes or an hour or so, you want to let your nursery staff know what kind of medications your mom has had, specifically if they're narcotics, because they're going to want to bring Narcan with them to the delivery room, and they're going to want to be prepared to administer that to the fetus if the baby doesn't breathe when it's born or showing signs of lethargy or not wanting to have good respiratory effort. So what about in the second stage? So the second stage is the pushing stage of labor, and it's important to note that this part of the labor and delivery process is a one-on-one care. You can't take care of any other patients whenever you are taking care of somebody in the second stage of labor. You have to be there at the bedside providing continuous monitoring. Continuous pain monitoring and coping abilities throughout this stage is key. We're going to bump up our maternal vital sign assessment to every 5 minutes, temperatures every 1 to 2 hours. We're going to be looking at the contraction pattern continuously because we need to know when contractions are happening so we can encourage pushing during those contractions. We are going to auscultate the fetal heart rate every 5 minutes and immediately after birth as well. And we're going to observe and assess for any signs of perineal lacerations, and those can occur in different degrees. You can have a first, second, third, or fourth degree. A first degree is a very small laceration in the perineal area, and it goes all the way to fourth degree, which means that the perineal area has lacerated all the way from the vaginal opening through to the rectum. So that is very bad. When a nullipara is prepared for the second stage, she's prepared for birth, you can note that when the perineum starts to bulge. And in a multipara, this progresses much more rapidly, the perineal bulging, so you might not see that as an assessment sign because it will happen so quickly. Promoting comfort, again, is key during the pushing stage. And most of the comfort measures that we've talked about already apply here as well. So positioning and fluid and ice chips to relieve a dry mouth, a cool cloth. Sometimes also the pushing might not happen spontaneously with these women. They may not know when it is time to push, which is why it's important for you to guide them through that process based on their contractions. Especially for women who have an epidural, she may not have that urge to push, so you have to encourage her through that process. Passive descent of the fetus during the second stage has been shown to be better than active pushing. So that means basically that allowing the baby to come down on its own without having the mom push so forcefully for such a long time has shown to be a better approach. So think of that from a station standpoint. It's much better for the baby to descend to 0 plus 1-ish station on its own than for the mom to push from +3 station all the way till the baby's delivered. They're just typically a better outcome. Assisting the physician or the advanced care provider during this point is the nurse's sole responsibility, and keeping the mom in a birthing position that is comfortable for her, and that lends itself to the best fetal descent and to the best pushing effort of the mom is very important. And sometimes it's a trial and error process. Some women might be able to push upright a little better. Some women might want to squat. Some women may want to kneel. Some of them, we also have labor chairs, like birthing chairs. So some women might want to sit. And typically in the acute care setting, though, you're going to see people in a recumbent lithotomy position. So meaning kind of semi-Fowlers, laying back, but probably a little lower than low semi-Fowlers, and then with the feet in stirrups. That's called lithotomy. What else do I want to tell you guys about the second stage? Provide them with feedback on the labor process, their labor progress too. If the mom is pushing really well, tell her that. Sometimes the feeling is different, especially if they have an epidural. They might not be able to feel what they're doing. So they may try pushing one way and it doesn't really work all that well. And you may help them change positions, or they may start pushing a different way. And you might have to say, hey, yes, that's it. I can see the baby moving down. That's it. Keep it right there. And that helps them to distinguish the differences between feelings so that their pushing effort works as best with the contraction as possible. If the advanced care provider has to cut an episiotomy, which is done with a pair of scissors, and they cut the perineum to allow the passageway to expand more for the delivery of the passenger, you might have to also help with that. Providing a perineum that's clean for the baby to come through. Some women have a bowel movement at this point when they're in the second stage, so keeping the perineum clean is important. Usually we utilize betadine, like a betadine scrub, and we can just squirt that on the perineum for the physician to sort of rub around and use down there to prevent infection. And then making sure that you've got all of your equipment needed for anything that might occur in the second stage. So once the baby's born, do you have everything you need there to take care of the baby? In the third stage of labor and delivery, so our third stage is our delivery of the placenta, and nursing care during the third stage focuses on the initial care of the newborn, so APGAR scores, vital signs, making sure the baby's warm. It focuses on enhancing attachment for the mom, so placing the baby skin to skin, and then care of the mother. So caring for her perineal area and making sure she is comfortable after delivery, during delivery of the placenta and afterwards. At this point is where you would do any kind of cord blood analysis. And again, that's really done to minimize any type of medico-legal exposure that could happen. Assessing maternal vital signs every 15 minutes is typically what we do in the third stage. Remember, it should only last 30 minutes or less, and if it lasts more than that, then we consider that a retained placenta. Getting a temperature every hour to assess for infection, assigning 1 and 5 minute APGARs to the baby, and then looking for those signs of placental separation in mom. So a rise of the fundus in the abdomen, the globular shaped uterus, a swift gush of blood from the vagina or trickle, and then a further protrusion of the umbilical cord. Those are all signs that the labor nurse can assess to tell her that the placenta is starting to separate and will be delivered. A vaginal fullness on exam is what the provider would feel. Typically, the nurse would not be doing that at this point. From an intervention standpoint, we have to obviously provide continuous monitoring to the mom and the baby, provide immediate newborn care. So we're looking at airway, breathing, circulation, and assigning those APGARs. We might have to instruct the mom to give a little push when we start to see the signs of placental separation to help aid in the expulsion of that. Document the time that the placenta was delivered and which side delivered face up, Shiny Schultz or Dirty Duncan. The nurse also will start Pitocin after the placenta is expelled, and we know that Pitocin increases the contractility of the uterus. So we deliver a Pitocin bolus after delivery of the placenta to keep the uterus contracted to prevent postpartum hemorrhage. And the reason why we do this after the placenta is delivered is because if we start it during the third stage while the placenta is beginning to separate and we contract the uterus and clamp it down, it might hinder separation of the placenta from the endometrial lining. So we always want the placenta completely expelled before we start that Pitocin administration. We collect the cord gas if the doctor ordered it, administer any kind of pain meds if there are some to be given or if the mom needs them. If she has an epidural, we will take that out of her back. And the catheter, epidural catheter comes with a different colored tip on the end. So typically the ones I've seen have a blue tip on the end of the catheter, and the reason for that is so you know when you pull it out that you have pulled out the entire thing. So that's always important to document as the nurse as well. Epidural catheter DC, blue tip intact. That tells somebody that you got all of it out. We also will help clean the perineum up and give mom an ice pack or a pad sickle. At this point, they do have nifty little things now that are like a perineal pad that you put in the freezer and keeps it nice and cold. We call them pad sickles. So helping her do her peri-care at this point is very important, and promote her to bond with the newborn. It is most important that moms start the attachment process with the baby as soon as possible after delivery. And if you can't do it immediately, at least within the first hour, particularly if they're going to breastfeed, because it increases the chances of success. Also, doing skin-to-skin contact immediately after birth helps with the newborn's thermoregulation and all kinds of other things that are beneficial. And research has shown and proven those things to be true. So in the last stage of labor and delivery, or the fourth stage, we are looking at maternal vital signs and pain. We are rubbing and massaging the fundus and checking the perineum. We are looking at lochia, the color, the amount, are there clots present? We're also assessing urinary output and bladder distension. We give Pitocin in the 3rd stage to keep the bladder, to keep the uterus contracted to prevent bleeding. But Pitocin also can cause urinary retention, and it can cause water intoxication. So keeping a really close eye on urinary output in the 4th stage is very important, not only because the labor process and the delivery process can cause bladder atony and cause it to kind of be in shock and not want to work, but also because you're giving a medication that has the side effect of urinary retention. And then promoting bonding, assessing that bonding between the mom and the fetus and the support person if they're there, or other family members. You're going to be getting vital signs every 15 minutes for the first hour, and then however your facility protocol has it set up, but usually it's for a 4-hour time frame. Typically, you're doing a vital sign every 15 minutes for the first hour, every 30 minutes for the second hour, and then every hour times 2 to make up that 4 hours. Fundal massage and assessment of lochia every 15 minutes for the first hour. And again, then that piece follows the policy's protocol. Monitoring her perineum and documenting lochia and any signs of hematoma. If she's had a laceration that's had to be fixed with stitches, or an episiotomy that's been stitched up, making sure those things are approximated. Assessing whether or not the ice packs you've given are effective. Are they helping? Giving her pain meds if she needs those. Warm blankets for the labor shakes, or again, pad sickles and ice packs for the perineum. We're still, during the 4th stage, administering that Pitocin to keep the uterus clamped down, and typically we will administer that bolus and then anywhere from 1 to 2 liters of Pitocin after that, depending on our assessment findings and the doctor's orders. We want to continue to encourage her to void during this point, because we know that a full bladder only wreaks havoc on the uterus and allows it to not be able to contract, so we see more bleeding. So making sure she's peeing is important. And then making sure that she has the opportunity to rest and eat and drink something. We've deprived her of all of those things for who knows how long, and helping provide her with an opportunity to do those things is important. And then giving that opportunity for bonding. During the 4th stage, initially, the healthcare provider also will inspect the vagina, the cervix, and the perineum for lacerations, and they'll make any necessary repairs. At that time, the nurse assists with that, so you may have to have some lidocaine available if the mom doesn't have an epidural or had no pain meds, so that the stitching up can occur. The nurse also needs to be continually assessing that uterus for firmness, so by doing that fundal massage and noting any clots or blood in the uterus. Those can be expelled by doing fundal massage, so you should also note that as well. And there's no need to massage unless the fundus is boggy, but you do need to palpate to make sure that it's firm. If these women have been in a lithotomy position for a long period of time pushing, encouraging her to move her legs, and if she has not had an epidural and can get up and walk, or just stand at the bedside or dangle on the bedside, that can be helpful. But if you can get the mom up during the 4th stage, it's really important to be cognizant that they might have some orthostatic hypotension because they've been lying down for so long, and they've had all these hemodynamic changes that have occurred. during pregnancy, and now intrapartally, and now we're postpartum, and there's still changes occurring in the hemodynamic system in the body. So being aware that their blood pressure could drop very quickly if you're changing their position from lying to sitting to standing. So someone needs to be there, and the mom needs to be educated not to get up by herself, even if she hasn't had an epidural, because of that particular issue. During the 4th stage, it's also important for the labor nurse to talk to the mom about how she feels about the process, or at least approach the subject. Talk about, possibly the pain that she felt. Did she feel empowered through the process? And assess her risk for post-traumatic stress syndrome, post-traumatic syndrome. Sorry, guys. Especially if things did not go as she had anticipated, or if there were some kind of problems. Okay, I'm going to stop here because I've been talking for a long time. That was a lot of information regarding the maternal assessment and the fetal assessment during the stages of labor. So I'm going to stop here, and I'll pick up with a new lecture recording on this particular PowerPoint in a bit. Thanks for watching.